Good morning, everyone, and welcome to MSA Awareness Month. And our topic today, Ask the Experts panel. Let me first share with you our MSA Coalition disclaimer. This educational session is not intended for the purpose of providing medical advice. All information, content, and material are for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. The information supplied through webinars or on our webpage or by any representative or agent of the MSA Coalition, whether by telephone, email, letter, or other form of communication, is for informational purposes only and does not constitute medical, legal, or other professional advice. Everyone, thank you for that. And I am honored to introduce you to our panel this morning. I will put in a proviso. Many of these individuals are currently working in their hospitals. And because of that, we have some substitutions and we have some ads. So let me first give energy to Dr. Gregor Renning, who could not make it with us this morning. We will miss you and thank you for all your support. And in turn, I would like to have you meet Amy Nguyen, Dr. Nikolaus McFarland, and Dr. Vikram Khurana. Dr. Vikram Khurana is literally walking down his hall after admitting a patient and will be here in just a moment. So with that, everyone, Amy, I would very much like you to introduce yourself and tell us a little bit about your MSA journey.
Good morning, everyone. Thanks for having me. I'm a nurse practitioner at Vanderbilt in Nashville, Tennessee, and I'm involved in both clinical research as well as seeing patients in my own clinics. I kind of fell into MSA and over the past several years have just kind of loved it and learned that the patients are so intricate and so complicated, but I really enjoy helping to take care of you guys. I am involved kind of with our trials as well as, bridging that with clinic. I also do see a lot of patients for autonomic issues. We have an autonomic clinic at Vanderbilt. We're very fortunate, but it's extremely busy and about a year wait to get in. So I've kind of helped bridge that gap a bit. And so that in itself keeps me pretty busy.
Fantastic, Amy. Thank you. Dr. Vikram Khurana has just joined. Thank you so very much. Vic, while you get settled, I'm going to ask Dr. Nikolaus McFarland to introduce himself and share his MSA story to date.
Hi,
Dr.
thanks,
McFarland.
Lisa. Yeah, thanks, Lisa. So I'm Dr. McFarland. I'm a board certified neurologist and a movement disorder specialist and associate professor of neurology at the University of Florida. I work at the Fixed Cell Institute for Neurological Diseases at the University of Florida. I've been there for over a decade now. And I've been pretty passionate about treating MSA and other atypical Parkinson disorders. I actually run a specialized multidisciplinary clinic there at the University of Florida for atypical Parkinson's patients. And I've done that for a number of years. Our referral base is pretty much the entire state of Florida and surrounding areas. And it's really been my pleasure to take care of patients like this and their families. So I hope that I can bring sort of a wealth of my experience to this and answer your questions today.
Dr. McFarland, thank you so very much. And last but definitely not least, Dr. Vikram Khurana, you are multitasking and walking at the same time. May I please ask you to introduce yourself?
Thanks so much, Lisa. And I'm sorry, yes, I did have a patient admitted, so I'm walking back from the inpatient service right now. And I'm sorry I'm off camera for just a few more minutes, but it's a real pleasure to be here. I'm the chief of the Division of Movement Disorders at Brigham and Women's Hospital in Boston and Harvard Medical School. I run a lab that is really focused on using stem cell biology to create personalized models from patients like patients with MSA. And we have a very strong interest in understanding the heterogeneity of the disease, the complexity of the disease through the window of a protein we've studied for a long time, which is called alpha-synuclein. As many of you know, many of the disease-modifying treatments right now center on this protein, and we're really interested in studying how it causes MSA. So there's a lot of basic research that we do, but we're also developing an innovative clinical trial service here at the Brigham, where our patients with MSA, when they come to see us clinically, really are entering a very quantitative longitudinal assessment where we assess the patients, study them from many different perspectives to match them to appropriate therapeutics. And we have a number of programs at that nexus right now of clinical and translational medicine. So we're extremely excited about what's happening in the MSA field. I've worked with MSA patients and their caregivers for more than a decade now. It is a disease that we all want to see disease-modifying therapies for, and it's just a real pleasure to be here and continue the interaction with all of you. Thanks for having me.
Everyone, I know you have crazy busy schedules. Thank you so much for being with us this morning. Patients, caregivers, and everyone on this webinar, as you participate today, if you have any questions or concerns, please direct them to the Q&A function on the Zoom, and I will read them out to the panel and they will graciously answer. Thank you for your participation, and away we go. All right. Blake has a question. Many drug trials that I have seen are for people who are in very early stages of MSA. For example, patients are able to walk independently or a few years after symptoms first presented. But MSA tends to be diagnosed only after symptoms have exceeded those of typical Parkinson's. Deep into the progression of the disease, is there any way to reconcile this problem? Blake, fabulous question. May we start with Dr. McFarland and then just work around the panel?
Yeah, Blake, I think this is a really tough question and a good question as well, and one that many of us who do clinical trials actually face quite a bit. At our clinic, we are doing a number of these MSA clinical trials, and I have to agree with you that most of the disease modifying, so when I say disease modifying trials, so currently we don't have a drug that's approved for MSA that slows the disease progress or even as a cure for the disease. And so much of the focus these days is on what we call disease modifying. We'd love to have that kind of thing, but disease modifying trials currently are indeed focused on that early onset of MSA, early onset patients. And I agree with you that they don't really address the patients later in disease. And it is true that even today, patients often are diagnosed later in disease. And so part of our aim is actually trying to identify patients earlier and to find markers of disease or early features of disease that might help either the generalist or the general neurologist refer patients earlier to us so that patients can be involved in these types of clinical trials earlier on. So, I mean, the goal ultimately is to try to diagnose this as soon as possible. And I think you'll hear from not just myself, but Vic and others about how we're actually doing that and trying to diagnose people earlier. So I'll let them kind of comment on some of that, but I think it's not really addressing your question about what about me if I've been diagnosed 4, 5, 6 years into disease. What do we do and what kind of trials are open for you? I think the sad part really is that the brain itself is a complicated organ, and I think one thing that we have learned over time is that it's hard to kind of reorganize the brain and to fix it later on in disease. And so that's part of the difficulty in targeting therapies later when the brain has degenerated so much already. That said, we are hoping that trials targeting disease modification will also be effective later, but that's going to be a focus for probably later trials. So unfortunately, most of these disease modifying trials still do focus on earlier disease, and we just need to do a better job at helping diagnose patients earlier. And that's really what we've been trying to do, is educate clinicians, look for better biomarkers, either blood or imaging markers that might actually help us diagnose MSA. It's a tough diagnosis. It really is. And as a clinician, I think I'm often the third, fourth, or even the fifth neurologist to have seen a patient before someone is diagnosed. And often it is late in disease that I see a patient, and that is often unfortunate because it delays appropriate therapy and opportunities to participate in trials. So it's a great question, but a complicated answer. I wish I could just answer it very simply for you. But there is much hope out there in terms of trials, and we're hoping to get patients in sooner and provide those opportunities. So I'll let others answer as well.
Dr. Khurana, welcome. Your
Hi,
thoughts,
thank
sir?
you. So I assume I've just got back in, but I assume the question was relating to the diagnosis and the challenges of MSA. I'm just picking that up from Dr. McFarland's last comment. Is that correct?
You are absolutely correct. And the frustration around drug trials are for early diagnosed individuals. However, due to the frustration in the diagnosis process, patients are often seen by movement disorder individuals later in their diagnosis and are not eligible for that trial.
Yeah, well, thanks for the question, letting me chime in on that. I think that from the coalition's perspective, there's that issue has been recognized, that the late diagnosis is just such a frustrating part of the journey for MSA patients and their caregivers. There is a really concerted effort on the basis on the part of the coalition to really up the ante on education of clinicians, not just in major teaching hospitals, but out in the community to really get the message out about about MSA and the newer methods that we have to diagnose it earlier, and what the telltale signs may be for MSA. So I think it's well recognized. There is a reason why clinical trialists are focusing on early patients, because they think that early patients may stand to benefit more from disease-modifying treatments. So I understand the logic of that, but also the frustration. It may have been mentioned before, but I think in the new diagnostic criteria for MSA, I think in those criteria, I think we see tremendous progress in the tools we have for diagnosis. And I think at Florida and here at the Brigham, I'm sure we're all we all have at our disposal many new types of tests. None of them are smoking guns yet for MSA, but it's amazing the progress that's just been made in the last 2 years for a variety of tests. These can be from the skin or the spinal fluid. These can be based on imaging, different types of imaging modalities. They need to be integrated carefully with the clinical picture. But I think our tools for diagnosing MSA early are really tremendous. And I think we've learned a lot clinically about early telltale signs of the disease, such as REM behavior disorder, that have also clued us in carefully on identifying patients with early MSA. So, so yes, very challenging, still distressing, but huge progress.
Dr. Khurana, thank you. Amy, anything to add?
Yeah, I think one of the unique features of MSA is just how difficult this diagnosis is, and that, it's not diabetes. We don't just have a blood test for it, and it takes patients years to get to the right place. And we have come very far in that, and, that doesn't help today, but it's going to help soon as we get this information disseminated, not just to neurologists, but to primary care doctors, to people out in the community that are seeing these patients. And, one of my hopes would be if you can get close enough to recognize, I don't know what this is, but I know where to send you. I think even that will be really helpful in getting patients to the right person earlier. And that's where those skin biopsies and more of this sophisticated imaging technology that we're developing is going to really shape the future.
Thank you, Amy. Guys, I'm going to turbo because we have 20 questions here on my screen, and I have another 15. So you asked the toughest question first, and I really appreciate that. So thank you for starting us off in such a great way. And we're going to move to Stephanie's question. How do you suggest MSA patients and caregivers determine which clinical trial is best for the patient? Is there a way to find out more about any given study's findings in previous clinical trials, i.e. phase 1 or 2? Dr. Khurana.
I think that for those kinds of, once you have the diagnosis, which is challenging, I think those kinds of questions can be best answered in conjunction with, someone who's, executing some of those trials, is involved in like tertiary level care for patients like this. These are complicated. Matching the right patient to the right trial is complicated. I think the bottom line is that we haven't had a disease modifying treatment yet emerge from clinical trials. There may be in the fine print of any given clinical trial reasons for suggesting it to one patient or another. But if the trial is being executed well and carefully, and if the diagnosis is correct, then really, if it's practical to be part of a trial and a patient is interested, there are few reasons for saying no to entering into a clinical trial for MSA. Most of these have been thoughtful. They're based on good, solid research. When they're properly run and supervised, they are appropriate. And we do not yet have the best tools available for matching drugs to patients. So I think the MSA Coalition website, step 1, clinicaltrials.gov, step 2, and I think talking with an experienced clinician researcher is step 3.
Thank you, sir. Stephanie has a second wonderful question. Under the Orphan Drug Act, is there any way an MSA patient can get the trial drugs prescribed for them outside of the clinical trial? It seems the act was created with the intent of broadening across to non-approved drugs to those who fall victim to rare diseases. So it would seem prescriptions should be allowed in situations like this where there are no available drugs. Dr. McFarland, and then over to Amy.
So I would basically say this, just because a drug may be available and sound like it might be a good idea for MSA, you may see one study published somewhere and you might find an article on Google or some other search, doesn't necessarily mean that it's actually a good idea. So I caution patients looking at this, and I really encourage people to ask your physician first, okay? There's a lot of stuff out there, and you really have to filter things very carefully from the internet and the web. And so I do get a lot of patients who read a study. It was done perhaps in a preclinical or lab-based manner, but for a drug that has maybe been approved for some other indication, such as maybe diabetes or HIV or some other completely different disease. And it's being tested and suggested that maybe this might work, but that's really an early stage study and doesn't mean that it's actually been tried for that disease or even in humans. And so, yes, while this is available with the Orphan Drug Act, we really have to be very careful about sort of crossing from, the bench to the bedside and doing careful research. So, drugs can have side effects. And, again, I want to really emphasize again for drug trials are not treatments. Those drugs are experimental. So when you take part in a clinical trial, you're taking part in an experiment. We don't know whether those medications are going to be beneficial, do nothing, or be harmful in MSA. And that's an important distinction for many patients and something really hard to understand. Yes, being a clinical trial provides hope, but going into a trial requires consenting and understanding both the potential benefits, but likewise the potential harm that a trial could do to you. So talk to your physicians, discuss things. There are other ways to, so there's different levels to this question as well. There are some drugs that have been in trials or in trials, and you may have heard of either both what's called compassionate use, and then there's also what's called expanded access to drugs that are being under trials. It's, in my experience, I have done this before, but it's not an easy process. And it really depends on the pharmaceutical company that's making the drug and the process that it takes from going from an experimental drug trial to reaching the FDA and getting it approved and then actually out in the drug stores. So that's a long process and it goes through a lot of approvals. And I think many of you probably have heard stories of drugs that have come out. They weren't fully supported and ending up actually causing significant side effects or harms to patients. And so there are lots of good examples for that actually out there. So I just caution patients. I realize that people are, we're all impatient. I'm impatient. I would love to have that cure tomorrow or even right now, but it is a long process. But I guess I encourage people patience. The system does work. It is slow. I get it. But again, I encourage you to talk to your physicians about the drugs that you're concerned about or interested in to make sure that it is safe and it's an appropriate drug to try. Okay.
Thank you, Doctor. A question to the panel to think about. Since we have so many questions, I know your schedules are very tight. Would you be, if you can check while we're continuing to discuss, if you are open to an additional 30 minutes, please let me know and we will hope to answer these questions. If not, we will answer them offline and get them to you via email. So doctors and Amy, let me know what works for your schedule. Meanwhile, Teresa asks, FDA approved a new treatment for ALS patients, and I'm not going to say this correctly, so everyone feel free to correct me. It's Relyvrio, Relyvrio. Can this be used for MSA patients, everyone? You're shaking your head, Dr. Khurana, so you've got this one.
So I would say there's the way that drug works, there are theoretical ways in which could be beneficial to other neurodegenerative diseases, and that's actively being investigated right now. I think it's still very much an open question. And it's amazing to have a new drug approval for ALS, but the results are modest, and we'll also get more experience from how that drug works in ALS over the next few years as well. I second what Dr. McFarland said. I think that we should be very careful and cautious about just translating one set of studies to another context, and we should be as careful and considered as we can when we try drugs off-label or we take an existing trial drug and implement it. There are ways, and increasing numbers of centers are doing this, of the middle ground, which is maybe not in the context of a large clinical trial, but for an orphan disease like MSA, taking a small number of patients and very carefully doing a small-scale study on a drug that we know is safe, but at least gathering very useful information quantitatively from the patients before they get the drug and after they get the drug. And I would, again, encourage you to talk to experienced MSA clinician scientists, providers for these kinds of options. So we are living in an era where genetic and pharmacologic, drug treatments are going into our patients earlier than before, which is wonderful. And this means the infrastructure for doing this safely and in a way where we learn something is also being developed in several centers across the country. So there are going to be middle ground options of trying these in a safer, more scientifically useful fashion and a safer fashion for patients. So those options are going to open up, and stay tuned.
Thank you, Dr. Khurana. Amy, I believe you have this at Vanderbilt. Clarify, what is the progress of ATH 434?
We have dosed one patient. We are actively enrolling currently. We just got up and going a few weeks ago. So we're really excited to get this off the ground, and so far so good. You know, it's just started, so I don't have too much to report yet, but to be determined.
Amy, if someone wants more questions or wants more information, how do they direct that to you?
I can send my coordinator's email to the group, and that would be the best person to reach out to.
That would be fantastic. Thank you so much.
Mhm.
Yeah,
Everyone.
that's the Alterity study, just for
Yes.
clarity. And
Yeah.
I think there are more sites. Our site is coming online very soon.
Awesome, Dr.
Actually, we
McFarland. I
should
did
be
not
on
know
site.
that.
Yeah, so there are more sites coming online, but it's also an exciting new trial for MSA.
Yeah.
Fantastic. Everyone, what should I know as an MSA-C patient about cataract surgery? Who wants to field that?
I can answer briefly, but I'm not sure what the question's asking about. I don't know if there's anything specific about the cataracts in MSAC that I'm aware of. However, I think the question might be about surgery and a procedure,
Yes.
in MSA, MSAC, I think if we think about MSA as a neurodegenerative disease and in that Parkinson's spectrum of diseases, and in general, what I recommend to patients who have Parkinson-like disorders, including MSA, and that includes MSAC, is that you're going to undergo some sort of anesthesia. Cataract surgery is not a long surgery like a heart surgery or a lung surgery, for instance, but it does involve anesthesia. And so we always recommend patients to tell your surgeons about your disease and the issues that you have. Make sure you bring a list of all your medications with you, and the times at which you take them. And then also understanding that anybody who has a degenerative disease, that your in-hospital experience might be a little bit different than someone who's not affected by, for instance, a Parkinson disorder. For instance, anesthesia can sometimes cause what's called delirium. That's confusion afterwards, that can lead to a more prolonged hospital stay or other complications. And so that's why it's important to tell your physician, maybe even have a brief conversation with the anesthesiologist prior to a procedure. So there's just general comments regarding that.
Thank you,
Chime
sir.
in, just chime in briefly and say, I don't know of any connection either, but vision is really important for balance. And so if you can find a good way to do this, this kind of procedure, it will help your balance. And with MSAC, there's, as you know, there's stress on the balance systems of the brain, and correcting vision is important. So if it can be done safely and carefully, it's a good idea.
Thank you, gentlemen. Red would like to know, some of my doctors are calling my illness MSA. Others say autonomic neuropathy. Are both the same? Thank you for your answer.
Do you want to go ahead?
Dr. Khurana.
Well, I would just say that they are, they mean very different things. I think that we would need to know a lot more about the medical story and the investigations that were done. I would say that autonomic neuropathy is a very large collection of potential disorders. It's not really a diagnosis. It can affect the central nervous system, the peripheral nervous system. MSA is a specific pathologic diagnosis, and those two should really be distinguished from each other. Autonomic function testing is a good way to start, and then a battery of different tests that are now available and described in the new diagnostic criteria, as well as a very thorough clinical evaluation, which is clearly the most important, really need to be done to make sure of the diagnosis. So the answer is autonomic neuropathy is really a general term. MSA is specific diagnosis. It can involve central autonomic neuropathy. So I think that those two things should be parsed apart, and an experience center will be able to do that.
Thank you, Dr. Khurana. Teresa asks, have you heard about a trial FGF-1 treatment for MSA?
I have not for MSA. It is being trialed. There is a trial for it in Parkinson's, but not that I'm aware of for MSA. It is called fibroblast growth factor 1, which is one of those growth factors that can affect survival of cells. In this particular case, fibroblasts, maybe neurons in the brain too, but as far as I know, no. I don't know, Vic, if you know.
No, I know of an intranasal study for Parkinson's disease, and that's the one that I know as well. I don't know if it's being tried for MSA.
Thank you both, gentlemen. Levon asks, after having PD for almost 7 years and being diagnosed with PD, then MSA, then Lewy body dementia, now back to MSA, how do you get a definitive diagnosis? Dr. McFarland first.
Well, it's a great question, and unfortunately happens all too often in some cases. So all I can really say is there isn't yet some sort of blood test for MSA particularly. I mean, there are new tests that are coming out that, but you should understand there is significant overlap in Parkinson disorders. So MSA is a disease that has a couple of faces. One of its faces, or how it presents, is very similar to Parkinson's disease. And so frequently can this be misdiagnosed early on as this is just a Parkinson's disease. Lewy body dementia or Lewy body disease really refers to what's going on in the brain. Actually, we really refer to it as Lewy body dementia, which is more of an umbrella term that includes both Parkinson's disease with dementia, as well as what's called dementia with Lewy bodies, which is characterized by really early onset dementia within the first few years of disease, and sometimes preceding the Parkinson's as well. So it's very confusing, all of these different terms. And what I would basically say is this is still primarily and foremost a clinical diagnosis, and you need to see a movement disorders specialist. And so seeking out somebody who's familiar with these different disorders is really critical in finding a center. And that's partly what the MSA Coalition is doing, to create centers, or to at least designate centers that are where you have expertise on MSA and these different diagnoses. Short of that, I think looking for those centers and asking around for physicians who are experts in this field to help you out. Now, maybe we can have a longer discussion about different markers that are being researched that may actually be helpful, but are not yet fully approved. For instance, there are brain scans that can be useful, and there's now a skin biopsy called the SIN1 biopsy that's potentially helpful for this, but is also being studied in a research trial to see whether this can help us distinguish between the different Parkinson disorders. So these are all part of this sort of group of diseases that overlap in a lot of different ways. Okay, and so that's the difficulty.
Thank you very much. Salome asks, any specific treatment or research trials for dystonia with MSA? Dr. Khurana.
I'm not, there are many trials for dystonia, symptomatic and disease modifying. Some of them are quite focused on specific genetic forms of dystonia. I would say I am not sure, we can ask Dr. McFarland as well, I'm not sure of any trials specifically targeting dystonia in MSA. That is not, I don't know of that. We do have drugs that are effective for dystonia already symptomatically, and they're used in patients with Parkinsonism across the board. And I think that, you know, if you haven't already explored the treatments of dystonia that are available, then they should be tried because they could well work. But I don't know of any trials for new agents and specifically targeting MSA-related dystonia.
So I would second that. And the way that, I guess there's two ways I think of dystonia and MSA. It's one of the symptoms of MSA that some patients actually experience. And you can sort of group it either in we call focal or limb dystonia, so abnormal posturing of a limb, like for instance, a foot or a hand. And then there's also we call truncal or axial dystonias. Those are involving the head, neck, or back. And so those are sometimes difficult. So the head can drop, the back may become flexed over, and there's a condition we call camptocormia that's not exactly unique to MSA, but can be seen. And so treatment is actually of these different types of dystonia, just it depends on the type. And so really talk to your physician about it. But some of these are very challenging to actually treat. And there are different forms of treatment, both medications, other therapies. Botox is often used for focal dystonias and even neck dystonias as well, but it really just depends on the symptom. So discuss carefully with your physician.
Dee Dee asks, and I'd like all of you to give a quick vignette because I think this is a fantastic question. My husband has been diagnosed in the last year, and we've been referred to the Emory Movement Disorder Clinic. We have an October appointment, but we know nothing about what happens at a movement disorder clinic. Teach us how this works for myself and for my husband. I'm going to start with Dr. Khurana, then go to Amy, and then to Dr. McFarland. If you can kind of share what your movement disorder or your autonomic clinic is about.
Well, in our
And what they
case,
shall expect. Thank you.
I think it could be very different in different places. So I think there's many ways to do this and many ways to do it well. In our case, a movement disorders clinic involves, especially when the MSA diagnosis is being considered, involves a multidisciplinary team. There are physicians, physician's assistant, nurse practitioner who are focused on this group of disorders in our clinic. There's physical therapy, social work as well in our clinic. And then, of course, we refer out to other providers. And so, you know, the part of our clinic that really is really engaged in that first interaction with patients is multidisciplinary and is really focused on getting the diagnosis right. You know, this has come up many times in this conversation, and I think this is our first focus in our clinic, and our different providers are very focused on that, as well as obviously giving good clinical care and symptomatic treatment. So generally speaking, you're seeing a group of physicians and also their partners from allied health across the board. You're trying to establish a multidisciplinary approach. And then in our particular case, as I mentioned, we pivot our patients very quickly to clinical research if they're interested, and that involves other things like collection of biospecimens, biometric analyses, imaging, and those kinds of things. But that is really going to be very center dependent.
Thank you, sir. Amy.
Yes. So as was previously said, you know, I really start at the beginning with these patients and make sure that we have a really good understanding of what's going on and what their specific problems are, because MSA can look very different in different patients. And then that, you know, the cool part about our clinic is we get to have such a great team model. I've got usually a speech pathologist there in clinic. I've got, you know, our rehab institute is down the street. And so it's really advantageous to the patient that we can kind of engage all of those team members from the very beginning. I tell patients that therapy is like a medication. I'm prescribing it. It's important. You need to do it. And so, you know, just really establishing those relationships is really important. And we like to get as much done as we can in one clinic visit, because a lot of times these patients are traveling from all across the country. And so that also bridges kind of, okay, can I call Jessie, my coordinator, and have her come over to clinic and talk to this patient about any trials that we have or any upcoming things down the pipeline? And so it's really just, hopefully, you know, it's going to vary a lot, but hopefully where you all are going to be seen has sort of that team approach, can kind of get as much done in one trip as possible.
Thank you, Amy. Dr. McFarland, sir.
I can't speak specifically about Emory. I can tell you what our clinic does, and I think very similar to kind of what Dr. Khurana and Amy were kind of mentioning. We have a multidisciplinary clinic, and what that really means is we try to book MSA patients when we know when we hear about the suspicion or question, we try to book patients in our clinic to see me or one of my colleagues who specializes in this, as well as seeing our rehab specialists for the first visit. So that means either physical, occupational, speech therapy, and actually having some communication before the visit can be really helpful, so we can kind of target what do you need. But we often want everybody, each of our rehab specialists, to actually see the patient. In addition, we have a couple of full-time social workers. So we ask the social worker at least touch base with the patient to ask, are there any particular needs? And social worker or case manager, if you want to call it, would be really helpful to kind of question about, what do you need? Is there care? Are there caregiver issues? Are there financial issues that you have? Questions, long disability, things like that. There are umpteen different questions that can be and then there are other people that are part of our team as well. We have a genetics counselor if genetics comes up. And then, as Dr. Khurana mentioned, early on, we really like to get patients involved in research. So we're very much interested in trying to help patients and, provide opportunities. And that can be very simply, either just blood draw for banking, genetics, getting people into imaging studies, or actually a full-blown clinical trial, and just letting them know what the opportunities are. So it can be a long day. So be prepared for probably about a half a day for a visit and meeting different people throughout that morning. And if you can contact beforehand, if that's not something you can do, that's a good thing to hear. And maybe those other things can be scheduled on other days and other appointments if that is possible for you. Okay.
Thank you all. Agnes, welcome back from a prior webinar. Agnes would like to know, can any of you suggest relief for neck and shoulder pain that naproxen, gabapentin, or acupuncture has not worked for? Dr. Khurana.
Well, it sounds like you've tried some reasonable things. I think maybe the devil's in the details here, and knowing what the nature of the neck and back pain, that can be very multifactorial. So I don't want to really jump out there and suggest some kind of medication or treatment is going to help in this case. I just think that you've tried reasonable things. I think that we need to get more medical information. Certainly, I'm happy to opine if I knew more about more of the details. But I think that having a good, thorough evaluation by a couple of different people for this symptom, which can be very vexing, is helpful. There's certainly other drugs that could be tried, but I'd hesitate right now to mention specific drugs with such little information.
Another question, can MSA and PD patients take Benadryl? Again, I realize this is a general question for a very specific soul. Dr. McFarland, how would you answer?
I would just say yes. Just understand Benadryl is a classic antihistamine and can cause fatigue. So it's not one of those non-drowsy antihistamines. So I don't see any contraindication necessarily. But if you're someone who gets really drowsy with antihistamines, consider the non-drowsy things like loratadine, which is also Claritin, or fexofenadine, which is also brand name Allegra. But in terms of your MSA and Parkinson's, there's no specific contraindication. From my standpoint, cognitively, if you're an older patient, some of these medications can cause confusion. And I know a lot of people sometimes use Benadryl to sleep, but for those patients who might be in their sort of senior years, I would hesitate unless you have really good experience with the medication and have no issues to take that. Just for fear of causing some confusion or other adverse effects. That's my take on that.
Thank you. Renee asks, my husband is an advanced stage of MSA and currently bedbound with hospice coming daily. He He can no longer speak, but is very cognitive.
Mm.
My question is twofold. One, the difficulty of communication is beyond comprehension, and I'm looking for any suggestions. Secondly, with your involvement seeing patients progress, what can we expect in the next coming months? John has been in his current stage for about 3 months. Amy, would you like to begin?
Sure. It's a hard question. I think that the most important aspect is keeping speech engaged or getting them engaged if they're not. That can sometimes get tricky with hospice because they don't always want to allow the other rehab services to come back out. It just kind of depends on the agency. But I've had a little bit of difficulty with that in the past. And, the perk of hospice is you get a lot more support. So it's a really hard balance. There are some kind of assistive devices that can be programmed to help as voice fades. Typically that has to happen a bit earlier in the disease process, just from my very basic understanding of where you guys are at. And everyone's very different as far as what does the next couple months look like. It's a crystal ball question is what I often tell patients. This disease is very slow. And the other caveat to that is, if there's a really rapid change or overnight decline, then sometimes I start to think about an infection or something else brewing. And then that kind of leads into another question of how aggressively do we want to treat and that sort of thing. And so that's something that you and your physician will just have to kind of work through and talk through over time. It sounds like with hospice there, you've got sort of the support that you need. I would just kind of bring speech therapy up and see if that's an option to have a speech therapist work with you guys in the home.
Thank you, Amy. Stacy asks, I've had the CND life science biopsy done and 2 out of 3 tested positive. Based on my symptoms, my doctors believe I have MSA showing symptoms of both C and P version. Would I be eligible for clinical trials? If so, how do I go to enter these trials? Dr. Khurana.
Hi, that's a great question. I think this is an exciting test, but it needs to be, as we mentioned before, it needs to be considered in the whole picture, the clinical picture and other diagnostic tests. So I would just urge everyone that there is no single test that definitively diagnoses this condition, but that this is a very useful one. So if the diagnosis is made with some level of certainty, so it's, we think of MSA as possible, probable, or established disease. So you might hear some of those terms in your physician's office. If it's possible, probable, or established, you may well qualify for a clinical trial. They have different criteria for entry, eligibility criteria. So this really needs to be discussed with your physician. In terms of how you would go about entering these trials, typically you do that through an MSA experienced center that is local to you. I don't know where you are, Stacy, so I'm not sure that I could immediately answer that. You could probably pop that in the chat and we can come up with some centers that are close to you, which are experienced in clinical trials and triaging for clinical trials. But that's typically the way you get into one of these trials. Sometimes you can reach out to the companies themselves that are running these trials, and their information is provided quite systematically at clinicaltrials.gov. So if you go into clinicaltrials.gov and enter multiple system atrophy in the search engine, it will list trials and it will list centers that are enrolling for those trials. If you're interested in those, there is contact information there given for various centers, and one of them could be close to you.
Levon asks a question, a statement actually. Hang on one second, Levon, I'm getting to you. hang on 1 second. Sorry, technical difficulties here. Here we go. I believe that her person has been with movement disorder neurologist from the University of Michigan, Mayo Clinic, University of Florida, and more. These are supposed to be some of the best, but they still cannot definitively diagnose. This is the crux of the question, though. At the last diagnosis, I was told it does not matter if it's MSA or PD because they are treated the same. Dr. McFarland, how would you respond to Levon?
Well, I would say, first, I think we've been emphasizing the difficulty for diagnosis between Parkinson's disease and MSA. And MSA, when you have the Parkinson's type, can be difficult to diagnose or distinguish sometimes. And the overlapping symptoms can make things very challenging. There are new diagnostic criteria that are helpful. There's some new tests that are available, but even those tests that are available, brain scans, skin biopsies, still leave us with this being a clinically diagnosed disease. So that makes it challenging. In terms of treatment, there is some truth in the sense that when we're treating Parkinson's symptoms in MSA, we rely on Parkinson's medications primarily. That's really what we have that's available today. We don't have any medications currently approved that are specific for MSA. So when you have Parkinson's symptoms as part of MSA, the first line therapy is using a very classic Parkinson's drug called levodopa carbidopa. So that's our first line medication, and second line medications are likewise Parkinson's medications as well. It just the current state of our clinical care is really based on symptomatic therapy. And so we kind of rely on those therapies that are available. And until we have new therapeutics that are out specific for MSA, we're relying on Parkinson's therapies for MSA, as well as, therapies targeted at ataxia or other features of the disorder, like the dysautonomia. So we're specifically targeting symptoms. So it can be confusing, but I hope that helps answer the question. Maybe others can weigh in as well.
Amy?
Yeah, I agree that, I'm sorry if my dog is going to be interceding. I've got people working at my house. A lot of what we're historically using are medications for Parkinson's because of that overlap, and some patients have more benefit than others. I would say that a lot of times when I try to wean people off of the medications we use for Parkinson's, sometimes we feel like they're not doing much, and then we try to take them away and they are actually doing more than we thought they were. And so I really encourage my patients, even if I'm just seeing them for research, to talk to their providers about trying some of those medications, because we don't know unless we've tried it. And a lot of times there's some confounding issues with blood pressure and that sort of thing, but we can work through those. And so just really kind of having, bringing those questions up with your neurologist or your provider is really important, because we can troubleshoot through some of those side effects and some of the, intricacies if we know about it. So I would just encourage people to try it before you say it's not going to be helpful.
Everyone, panel, it is 9:57. A question to the team. Team, are you able to stay on for an extra amount of time to continue to answer questions? Or would you be able to answer these questions in writing afterwards? You're on. Awesome. Vic, I know you're going to be on until you see patients. Amy, do you have 30 more minutes in your schedule?
Yes, you may hear some drilling in the background, but I'll be around.
Duly noted. Everyone, thank you so much. Patients, thank you for being so supportive and your questions. I want to talk about brain donation, brain and tissue donation. When choosing where an MSA patient wishes to donate their brain, how can they be sure there's information sharing among interested parties? And how can they be sure that the organization is specifically for MSA research rather than a broad-based Parkinsonian research program? Example, I'm participating in research projects at Johns Hopkins, Mayo, and Hershey. I chose Hopkins to give my brain. However, it appears that Mayo may do a more MSA-specific research study. How to choose is a bit confusing. I'm going to jump in for just a second and give you a resource that works very consistently with the MSA Coalition, and that is the Brain Support Network. And specifically, that individual is Robin Riddle. She can be reached, and I will put this in the chat, she can be reached at number 650-814-0848. And my experience, I'm a clinical social worker. So let me give you why I'm answering this question. Thank you. Is that you need to advocate for the wishes that you want. And you're asking all the right questions. Each institution that you've referenced obviously has a team that is experienced in what they're doing and how they do it, but be very open in advocating for yourself and the wishes of how you would like your donation to be respected and the type of information that you would like. Panel, is there anything you would add to what I just spoke about while I put this in the chat? Okay, hang on one second.
I would second that. I think that if you're engaged in research, you have the right, you're being very generous about participating in research, and you should be talking to folks at these different institutions that you're interested in and find out about their research program and how they might be using your generous tissue or brain donation. I think these are all great centers. They're involved in broad research. Sometimes there's different types of research that could be very useful. Distinguishing in simple terms, is it just on MSA or is it Parkinsonism, may not necessarily be the right way to kind of classify this research, since there are interrelationships among the different types of Parkinsonism, and there could be very exciting research that could be called Parkinsonism research that could have very real benefits for MSA. So I don't think you should be necessarily going into this too restrictive about how that research is going to, the path of research is often, I would say, unpredictable. So I wouldn't necessarily go into this with thinking that someone will be able to specify every possible type of research that can be done. However, I think understanding what type of research the center has done, what they're interested in, what they're excited about, and whether that aligns with your own goals in general is a really healthy conversation to have.
I want to just weigh in on this too. I think, first of all, I would say thank you. Your gift and donation is amazing, and it really makes a difference. The more tissues we have access to, the more researchers can, do studies on these tissues, and that's an amazing gift and very generous. I would second what Dr. Khurana said, is that, if you're thinking, we want to respect your wishes, number one, I think, but if you're thinking that just, I want this only for MSA, I think one perspective to kind of see is exactly kind of what Dr. Khurana was mentioning, is that, it's surprising where we find results and we find our answers. And sometimes they come from the weirdest and completely unrelated research. So in a way, I think listening to the researchers and hearing that they're doing research on Parkinsonism or some other disorder, it might actually benefit MSA. I often tell patients, a lot of these diseases, from Alzheimer's to MSA to Parkinson's, we find a normal protein that seems to go rogue and cause disease. I say rogue because I think they're normal proteins and they misfold, and they cause stress in the brain and cause degeneration over time. And we don't fully understand that process. But I do strongly believe that if we can crack one of these, then it may have specific carryover to other disorders. I think it will really open up research for other diseases if we can find solutions. I'm certainly not of the the camp that, it's all going to be perfectly, if we're going to fix one, we're going to fix everything. But I do think it's going to provide significant, insight into other disorders. So just hearing the perspective from the researchers will be really important, and understanding that whether it's specific for MSA might not be the most important thing. Allowing researchers to have freedom and to make those crazy discoveries actually sometimes are the most valuable ones. So
Thank you for your pearls of wisdom, everyone. A question. Do you know of any neurologist willing to make an expanded access or right to try request for any therapies? That's a term I have not heard before, gentle persons, so feel free to educate me as well.
So I
Lisa,
think
can I
Dr.
answer that brief, or whether maybe Dr. Khurana has experience? I don't.
Dr. Khurana.
Yes, we've done that before, and we've done it in a couple of different ways. I can tell you how we've done it. We've taken drugs that are in, for example, phase 3 clinical trial, and we've been more interested not necessarily in whether the drugs are effective or not, but how they work and whether they engage their target the same way in different patients. So while we're answering a scientifically, I think, important question, companies have given us access to their drug, and therefore patients got access to the drug. And so that has been one way in which we've done this. And we then ask the FDA for expanded use. And then that can be done in a couple of, there's a couple of different categories, but when you do have an orphan disease, a disease that doesn't have a disease modifying therapy, a disease that can make patients very sick, then the FDA can approve expanded access, and it is done then in the context that's defined in the agreement with the FDA. So that's one way in which we've done it. Another way we are actually planning it with the FDA right now is that in our department we've developed a new drug that dampens inflammation in the brain. It's been used in MS and Alzheimer's disease. We're interested in what it does in MSA. And so we are again enrolling patients on the basis that drug may become available to them if the FDA approves it under expanded access. So there's a variety of different ways in which we can engage with the FDA and ask them if a drug may be appropriate for a patient. And just to reiterate what I said before, it's being the way we have done it, and I can only speak for ourselves here. This is done in many different ways and in many different valid ways. But the way we have done it is to try and carefully follow our patients over time, and to do them in the context of appropriate supervision and gaining what we hope is useful information for the scientific community at the same time. I think just putting random drugs in patients without thinking about it too much is something that we should be very cautious about, because as Dr. McFarland said before, these are experiments. These are not drugs that we know are effective. And so I think we should very carefully consider our options for each of these types of experiments, because that's what they are. They are experiments.
Thank you, Dr. Khurana. Joel asks a question, and in your chat, gentlemen, I have listed all the studies that she is asking us to comment on, along with Amy. Of all the disease modifying therapies currently being studied below, which ones seem to have the most promise? And I have listed those in your chat, gentlemen. And Amy, would you care to comment, or would you like to have this as a written question afterwards?
Nick,
Joel, this is a fantastic question. Go ahead.
Yeah, I think this is a really tough question to go through each of these trials.
I do too.
There are different stages in some cases. Some of them have been tested, like rituximab was tested and found unhelpful. And so there's some examples here. Some are still being started. ANLA 138B is in Europe, but not yet started in the United States. There are different stages. There's the Lundbeck, the LU is a Lundbeck trial that we're still doing. So everything's at different stages. And each one of these drugs actually have different mechanisms of action, but they're all experimental drugs. And so commenting on each one would be a kind of a long and drawn out and specific, and
Joelle,
pitting one against the other is hard to do. So bottom line.
we will answer that written afterwards. I just didn't want you to think that we ignored you. Thank you so very much. A question: how do you treat your MSA patients who have been battling the disease for many years, who don't seem to qualify for trials because of the length of time they have the illness, yet continue to decline? So basically, method of treatment for late stage MSA patients. Dr. Khurana.
I think there are a couple of different approaches. Again, I think this is very center dependent, and there's no easy or right answer to this. It's a very challenging clinical situation. I think the first priority for the Movement Disorders Center is to provide excellent clinical care, the best kind of clinical care. At this point, as you all know, this is symptomatic treatments. It's looking at not only like treating active symptoms, and we can obviously go into each of those, that depends on the clinical situation, but also preventing, Amy mentioned before, infections, and we have to be thoughtful about the kinds of things that can be happening in advanced disease. And so preventing complications like infections is really important. So the first priority, I think, for most centers will be treating the patient and giving the best possible clinical care for the symptoms. And that's where experience is, I think, really important. I think that we often see patients who have symptoms that are treatable, and whether it's bowel symptoms, bladder symptoms, I'm going to throw in mood, depression, anxiety, really important symptoms that can be effectively treated. So I think we should never resign ourselves to advanced MSA cannot be treated. There is often, whether it's physical therapy or it's pharmacology, there's often very effective treatments that can help symptoms and quality of life. So that's where that's something I would focus on. Now, in terms of, there was another aspect to this question, experimental therapies. You're absolutely right. Most of the active trials that are targeting disease-modifying therapies are targeting early stage patients for the simple reason that that's where we think those drugs are likely to be most beneficial. And that can be distressing for patients, but there is some scientific backing for that idea. There are going to be some centers, we are actually one of them, that are interested in studying how the drugs that are actively in clinical trial are actually working and how they engage their targets. And in those cases, in a recent trial we did, we had all comers participate in that particular trial because the question we were asking was very specific. It was very specific to how the drug engages its target. So the patients were longitudinally tracked over a period of time, given the drug, regardless of their stage, and we compared the outcome to how they were before they got the drug. So that is probably a newer way of doing this kind of thing. It's a carefully constructed clinical trial, but it's longitudinal. It goes over time where we study the patient before and after the drug. So centers, there are going to be certain centers doing that as well. I hope that answers it, but those are the two aspects of the question that I picked up on.
Thank you. This is an interesting question. Are previously studied treatments like intranasal insulin, IV immunoglobulin therapy, Bydureon, or minocycline, minocycline, BID, being used in MSA patients? Have these treatments been used? Dr. McFarland.
It is an interesting question. I agree. I am not aware of insulin being tried in MSA. IVIG, or what's called intravenous immunoglobulin therapy, has been a subject of investigation over time. There has been some thoughts that part of the MSA in some individuals may be mediated by an autoimmune kind of phenomenon. So what that means is our immune system fights off infections, but sometimes identifying what's foreign versus you is a little hard to do for our bodies. And sometimes our immune system ends up attacking our own body, our own cells, and causing we call autoimmune disorders. There are many, from thyroid disease to neurological disorders that are caused by immune. So IVIG therapies have over time been tried. It's a controversial subject, but generally has not been very helpful. Minocycline, I'm not as familiar with the minocycline trials in MSA, although I recall some. So maybe Dr. Khurana, are you aware of those too?
I'm not aware of minocycline being actively used now. Obviously, there was a unsuccessful clinical trial before. I'm not sure that we have not certainly used that, off label or anything like that. We consider that question addressed already by the field. Having said that, there are a number of other agents targeting inflammation in different ways, and those are either in clinical trial or coming towards clinical trial. And I suspect that the biology of our patients is different. This is just this is just me speaking from a hunch that there could be many paths to MSA and that different drugs may be appropriate for different patients, and that I think collectively the research community is trying to understand those differences among our patients better now, and hopefully all working towards targeting the mechanism in a specific patient with the right type of drug. And so I think that's why it's very difficult for us to give advice on which trial is better or what drug is going to be more likely to work. Some patients may respond to certain drugs and other patients may not. And I think more and more of our studies will be directed towards that kind of analysis.
Thank you both. Jason asks, and he references a study as well. Well done. Studies have been run to determine the timing for the development of MSA features found on an MRI. It often takes 3 years to diagnose MSA. Question: could diagnostic criterion measuring the difference in cross-sectional area between a pair of MRIs 6 months or 1 year apart be useful in finding subtle brain changes in the area of the brain that are tending towards developing the signatures of MSA? Dr. McFarland, do you want to start?
Sure. I think it's a great question, and it's certainly a possibility. We are doing, I think many centers are actually doing MRI imaging studies to look at early disease. I think the issue is actually identifying patients really early on. And so I think one of the really useful things of the new MSA criteria recently published is the possible prodromal. They're kind of a research criteria for identifying patients. It does increase our sensitivity for identifying patients and getting them included into potential trials. And we are, along with other centers, been involved in doing MRI studies, various types. MRI is interesting because we get lots of different images on patients and look at different things. So looking at the structure of certain anatomical features in the brain is one way to look at things, but also looking at the features within those structures sometimes is useful. Iron content, water, and particularly one of the studies that we published was about free water diffusion in brain and using that. But we need to, I think the next steps, now we've identified some markers, is to go back to early patients, really early, identify early patients. That's a challenge, and do longitudinal studies. So it's a great question, and does have some scientific basis.
Dr. Khurana.
I'm just going to, I second everything. I think all of our centers are looking at imaging in different ways, and I think this is a really exciting area. I just think the idea of studying our patients longitudinally is a really important one, because I think that, that how an individual patient changes over time and mapping their trajectory could be very vital for understanding whether that trajectory changes when they are given a drug or something that's meant to modify that trajectory. So I think this kind of research is really important, and we're going to start seeing, not just with imaging, but in a variety of different ways, longitudinal tracking of our patients. So I really welcome that question. I think it just has implications beyond imaging as well.
Thank you so much. I do have a question on the amulet study, but that's a specific question. So I'm going to ask the team to answer that offline. However, Marie has a really good question. She's an MSA patient and she wants to know, what are the treatments available for constant urination? Amy, do you want to start?
Yeah, sure. There's several. There's, just our medications that we use with other conditions like prostate conditions can actually help depending on what the urination problem is, if it's a retention issue or spasm or what's going on. I've had some patients that see urology while they're here, and they can actually do Botox for bladder spasm. That's been really beneficial. So it's a really case-by-case basis, but a lot of patients have had very good results from those medications and from those treatments. There's also bladder stimulators out there, and it's sort of like a spinal cord stimulator in the other world, where you actually get to sort of try it and see if it's helpful for you. And then they would actually implant the device. That's been super helpful for a lot of patients. So I think a good starting point, if she hasn't already seen a urologist, would be seeing a urologist and see what they might recommend. And I'm sure there's more than just one that has a lot of expertise just with Parkinson's patients. And I've had a lot of luck with kind of the bleed over into MSA with that. So that's what I would encourage her to do.
Thank you. An anonymous question, but a really good one.
Can I just chime in very, very quickly on that last question?
Absolutely.
Just
Thank
a general
Dr.
comment,
Khurana.
because I see another question that talks about looking at erectile dysfunction and urodynamic issues, and is this included in training and education of urologists? I think that really feeds into what Amy just said as well. And really, I was thinking about this as she was chatting, that I think a good partnership between neurology and urology is really important, because sometimes they are going to treat urinary dysfunction, for example, as if it were maybe a prostate issue in a man, and we might have different opinions about what's causing that. And I completely agree that quantitative urodynamic studies from urology are invaluable, but we should work together as a team and educate each other. I find that to be very, very helpful, because our trainings are so different.
Thank you, Dr. Khurana, very much. Another question with regards to ASO therapeutic approach via intrathecal route, aiming to reduce synthesis of alpha-synuclein and consequently to decrease misfolding, aggregation, and spreading in the ASO reached brain structures. Do you think a high alpha-syn inhibition in spinal cord and superficial cortical regions, but very low in deep structures like putamen or deep layer cerebellum could have an impact on the clinical progression? Whoa, that's intense. Who would like to begin this discussion?
I can just answer really quick this question. The answer is kind of maybe, and without giving away any kind of trial that's being put together, but I can just tell you there's clinical trials coming to answer this very part of this very question very soon. We don't know the answer yet, it hasn't been tried in MSA yet, but it's an interesting approach.
That's where that bleed over from other diseases. So why research is so important in the whole community. We tried this with Huntington's disease and we were not successful, but we're still trying and adapting. And so that's where just being a part of research in general is so helpful, because there is such an overlap with all of these diseases that we're treating.
Marie, you asked a question about clinical trials in Canada. We will answer that for you. We do not have an answer for you now, unless, gentlemen, you have information. Otherwise, we will be glad to answer that offline.
We have a Canadian patient that flies here, so I don't think that there's many trials there currently, but that's my only caveat.
Dr. Khurana, Agnes would very much like your contact information. If you could provide that in the Q&A, that would be fantastic.
Sure.
Nancy shares with a prior question. I love this. Please share with the patient family with good cognitive skills but no speech that there is a computer program that my brother used that let him spell words with eye movement. This was slow and required patience, but at least may give them an option. And I will chime in as well and say that's where your speech language pathologist can work with you to give you information about those type of mechanical devices and can help you. And hang on one second. Anonymous question. My husband's hands and feet are always cold. What causes this? Do you have any suggestions? Thick socks are not helping. Who would like to take that question? Amy, thoughts?
It's a hard one to treat as well. I just had a patient yesterday that wears really kind of cool, I think they're Bombas is the brand. They're just compression socks, but they're a little bit more sporty. It's more for circulation, but we think that that relates to this cold hands and feet. It's like I said, it's not an easy thing to treat other than with kind of external warming. Like those thick socks, it may sound simple, but that's my only recommendation. I don't know if you guys have anything different that has been helpful for patients.
Nick, do you have anything that you recommend? I also find it quite difficult. I think sometimes there's a painful aspect to it, and we try a couple of different agents for pain, Neurontin and a couple of other things if there's a painful component to it. But the actual feeling of cold and the discoloration, you know, other types of treatments that are used for Raynaud's don't seem to be great options here. And again, I don't know if Dr. McFarland has other experience, but I've also found it hard to treat.
Yeah, I would echo that. It's a difficult symptom to actually treat. It is we call it Raynaud's type phenomenon, this discoloration of the distal, the limbs and the hot and cold. And it probably is part of this, we call someone mentioned the word autonomic neuropathy that patients have. And I think I agree, if it is uncomfortable or painful, that there are neuropathic pain medications that might be helpful. But in terms of the cold sensation, it's really a matter of thick socks, I think, have been really the best thing, or trying to warm the hands. Okay.
It doesn't help with some of the standard treatments, you know, for this kind of thing, lower blood pressure, of course. So in the context of MSA, some of those agents are really not easy to use.
Yeah.
Everyone, I sincerely apologize. This has to be our last question, but before I go, I want to sincerely thank the panel for your time and energy this morning. And more importantly, MSA patients, care partners, and those impacted. Your resilience, your energy, and your questions are simply phenomenal. We are honored to support you in every way possible. We will work to continue fearlessly to do so. If we have not answered your question this morning, I will direct these to our panelists and we will answer them in writing and get them back to you. And finally, if we have not answered your question, I would refer you to our next webinar. Why do I care about research? Many of your questions were research focused this week. So if we did not get to them, bring them next week. For the panelist will be Dr. Daniel Clausen, and Pam Bauer, our chair of the MSA Coalition. And for everyone, that will be Wednesday, March 22nd from 12 to 1 Eastern Standard Time. And finally, the last question is, help me understand when it is the appropriate time to bring in palliative care. I think this is a critical question and one that sometimes is not answered. So everyone, if you would like to give your opinion, I'll start with Amy and then move on, and we will conclude with that. Amy, please.
Yeah, I think it's a very personal decision. I also really encourage my patients to engage with palliative care early, because there's a lot of things that, you know, we can think about and plan ahead for. I don't like to get to a situation where I need something and it takes weeks to build a wheelchair, you know, like I really like to get ahead of it. And so I try and kind of encourage palliative care, as this is not just planning for your death. This is planning for how do we really, you know, honor your wishes as we go. And it's never too early to even have a one-time conversation with a palliative care specialist that can talk you and your care partner through kind of, you know, the legal aspects of these things, POAs. It gets complicated. And so, you know, just having that foresight into these are the things that are important to me can really just take that burden away. And I think that's important as we go through this journey.
Thank you. Dr. McFarland.
So this is a really good question, and it's an individual patient question, I think, and something that you should have a conversation with your physician about. I am a strong believer in actually bringing up these issues early and discussing. MSA, you know, like with Parkinson's, is unfortunately progressive, more rapidly progressive than Parkinson's disorder. That is something we don't have a cure for or anything to slow it down. So bringing up issues about your wishes about care, talking about end of life, the type of care and quality of life that you like, spirituality, bringing these things up early on. It is a difficult thing to talk about, but even having that 5 to 15-minute conversation, if that's what it is, can be really useful to have. And just starting the conversation earlier can be very useful. Many, I think, patients often kind of don't think about it, or I think some physicians are a little uncomfortable talking about these issues. But I'm saying that there are lots of different ways to care for a patient with these disorders. And, you know, every patient and family I've met actually has specific differences, whereas one may want to have everything done, possibly under the sun, be involved in every single trial, whereas others, you know, are a little bit, they want more comfort. That is they don't want to be in the hospital, they don't want to be part of trials, and that is their, you know, their style, their wish. They're emphasizing, I want my loved one to be home and to have as much time as I want with them, and I want their end of life to be comfortable, and the choices you make. So that this is a really tough conversation, but knowing when, there isn't one moment. I think, you know, in general, if there's a significant amount of pain, discomfort, or low quality of life, is often things that are that weigh towards going towards palliative care. And I would say palliative care is a big term. Palliative care includes hospice, but so much more about it is palliative care than just hospice or end of life. Palliative care can be started much earlier in disease to help with comfort and quality of life, and even your feeling about your disease, your spirituality. So there's so much more to that. It's a big word to kind of unpack, actually, but I'm so glad someone asked this question, because I do believe it's really important to step back from us as the doctor role and just using pills and things to fix patients when they don't always work, and to consider these things and ask those hard questions about how do you see yourself about your disease? How do you see yourself going forward? And how would you like, you know, we all have our end, how would you like that to be? And how can we help make that possible?
Thank you, sir. Dr. Khurana.
Completely agree with everything that Amy and Nick said. I think that palliative doesn't equal hospice. I think that having them as part of the team early on, maybe talking to your whoever's part of that team, your physician, it might be the social worker that's involved in your team, but asking for your team to be connected with palliative care, if that's not offered early on, I think is a really great idea for patients, because even way before we start thinking about the disease being terminal, our palliative care colleagues really focus on quality of life and symptomatic treatments, and they often have perspectives and methodology that we don't have as movement disorders neurologists, and they can provide a lot of richness to the team and the clinical care. So I appreciate the question, agree with everything that was said. They're really great partners in this.
Everyone, thank you so very much for your time today, outside of your clinic, outside of your patients, outside of life. Patients, caregivers, thank you for your honesty and your trust in us. We as the MSA Coalition are honored to support you and look forward to working with you now and in the future. Have a great afternoon, evening, morning, everyone, and we look forward to seeing you next week. Thank you and goodbye.
Thank you.